Here is a discussion on aortic dissection, mechanisms and classification. Aortic dissection usually starts as an intimal tear either in the region of the aortic valve or at the region of the ligamentum arteriosum just beyond the left subclavian. That is a site where the ductus arteriosus was there in fetal life. And another mechanism of aortic dissection is rupture of a vasorum within the media and a hematoma forms which can later seep out, causing a rupture of the intima as well, and will act as a dissection of the aorta. Now, there are various classifications of aortic dissection. This is a famous DeBakey classification of aortic dissection. When the rupture of the intima is occurring in the ascending aorta and the dissection is extending at least till arch of aorta, it is type 1. But it need not stop at arch of aorta. It can extend down even into the descending aorta and sometimes even into the iliac vessels. Extensive dissection can occur. That is type 1 DeBakey aortic dissection. And when it moves on, the dissection can involve the ostia of the major vessels. Involvement of the cerebral blood supply can cause unconsciousness. So this is a pretty serious condition and usually in the surgeon's domain, needs urgent surgery, type 1. Another is type 2, which is a more restricted one. It is only involving the ascending aorta. It is not involving the arch or arch vessels, type 2. Then type 3 is without involvement of arch or arch vessels, only descending aorta. This can be either in the thoracic aorta or sometimes abdominal aortic dissections can also occur, which is relatively milder condition, often managed medically by control of hypertension and other risk factors. Usually these conditions may improve when you treat the hypertension, but this will definitely require surgery. In that condition also you have to treat hypertension, which is usually associated, and you will have to decrease the inotropy of the left ventricle by giving beta blockers. Giving vasodilators alone can increase the aortic wall movement because of decrease in peripheral resistance, and the ejectile force of the left ventricle can cause propagation of dissection. So if at all you are using a vasodilator, it should be combined with beta blockers to reduce the inotropy of the left ventricle. That is initial management only, but usually this is managed surgically. DeBakey classification of aortic dissection. Then there is another simpler classification, that is Stanford classification. That is simply ascending aorta is involved, it is A. If ascending aorta is not involved, it is Stanford type B. Then you see that this dissection is occurring near the aortic valve. Such dissection can also occur post-cardiac surgery patients, that is those who have undergone aortic valve replacement. Initial detection of dissection may be by echocardiogram. You may be able to detect the dissection flap moving within the ascending aorta. But nowadays the best method is to get a CT angiogram of the aorta, which will delineate the dissection flap and extent, especially lower down extent. It cannot be seen with echo alone. Similarly, this descending aortic dissection alone may not be visible in transthoracic echo. This can be seen in some cases with transesophageal echo. But in transesophageal echo, these regions may not be seen well because there are air passages in this region. You have the trachea and the bronchi, division of the trachea, which can prevent good visualization of these regions by echocardiography.